Good morning, everyone. This is Dr. Shilpa Garg, Assistant Professor, Department of Anesthesiology, Sri Lakshmi Narayan Institute of Medical Sciences. Topic of my class today is blood and its products. First of all, we'll discuss the definitions of blood and its products. What is blood product? Any therapeutic substance which is prepared from human blood is called as blood product. What is whole blood? Unseparated blood collected into an approved container containing an anticoagulant preservative solution is called as whole blood. What is the definition of blood component? Any constituent of blood which is separated from whole blood. Examples of blood components are red cell concentrate, leukocyte-reduced RBCs, platelet concentrates, fresh frozen plasma, cryoprecipitate. And examples of plasma derivatives are albumin, coagulation factor concentrates, immunoglobulins. First of all, we'll discuss about whole blood. As we all know, whole blood is collected by venesection. 450 ml of donor blood is required. 63 ml of anticoagulant preservative solution is added. Whole blood has no functional platelets, has no labile coagulation factors, that is coagulation factor 5 and factor 8. Infection risk. It is capable of transmitting any agent which has not been detected by routine screening, including HIV-1, HIV-2, Hep B, Hep C, syphilis, and malaria. Storage temperature for whole blood is strictly between 2 to 6 degrees Celsius. Shelf life is up to 5 weeks. Transfusion of whole blood should be started within 30 minutes of removal from refrigerator, and it must be ABO and Rh antigen compatible with the recipient. Complete transfusion within 4 hours of commencement. So what are the indications of transfusing whole blood? First indication is red cell replacement in acute blood loss with hypovolemia. Then in cases of exchange transfusion, then in patients needing red cell transfusions where red cell concentrates or suspensions are not available. Next, what are the contraindications of whole blood? In patients with chronic anemia and incipient cardiac failure, whole blood is contraindicated because of the risk of volume overload. Next, a unit of whole blood, that is approximately 350 ml, will increase hemoglobin by about 0.75 gram per deciliter in an adult patient, but an adult patient who is not actively bleeding. In pediatric patients, the transfusion of 8 ml per kg, now this is the dose in pediatric patients, transfusion of 8 ml per kg will increase the hemoglobin by approximately 1 gram per deciliter. Next component is red cell concentrate, or popularly called as PAG RBCs or plasma reduced blood. They are obtained by apheresis collection or prepared from anticoagulant whole blood. Following centrifugation, plasma is removed and 100 ml of additive solution of glucose and adenine is added to maintain the viability of red cells. Each unit of red cell concentrate contains 200 ml of RBCs and hematocrit is around 55 to 75%. Infection risk and storage requirements of PRBC is the same as that of whole blood. Now, what are the indications of packed RBCs? In cases of replacement of red cells in anemic patients and acute massive blood loss, same as that of whole blood. A solution of citrate phosphate dextrose adenine, CPDA, is used as anticoagulant in the blood. Citrate prevents the blood from clotting by removing calcium ions from the blood. Adenine is required to maintain the metabolic activity of red cells in the packed blood. Red cell concentrates in CPDA are kept at 2 to 6 degrees Celsius and shelf life is around 35 to 42 days. Now, a word of caution, RBC units which are stored for longer periods, that is more than 2 to 3 weeks, may lead to adverse effects because of senescent RBC fragments and impaired nitric oxide production. Next component is red cell suspension. 150 to 200 ml of red cells with minimal residual plasma, to which plus minus 100 ml of normal saline, adenine, glucose, mannitol solution, that is SAGM, or an equivalent red cell nutrient solution has been added. That is called as red cell suspension. Hemoglobin approximately 15 gram per 100 ml, not less than 45 gram per unit. Hematocrit is around 50 to 70%. Infection risk and storage are same as that of whole blood and packed RBCs. Shelf life is longer than that of whole blood, that's around 42 days. Indications is same as red cell concentrate, that is replacement of red cells in anemic patients with acute massive blood loss. Next components are leukocyte depleted red cells. A red cell suspension or concentrate containing less than 5 into 10 raised to power 6 white cells per pack, prepared by filtration of an leukocyte depleting filter. Hemoglobin concentration and hematocrit depends upon whether the product is whole blood, red cell concentrate, or red cell suspension. Leukocyte depletion significantly reduces the risk of transmission of cytomegalovirus. So this is the major advantage in leukocyte depleted red cells. Infection risk is same as whole blood. Storage is 2 to 6 degrees Celsius for 35 days. Leukocyte depleted red cells, they minimize white cell immunization in patients receiving repeated transfusions, as leukocytes in the blood units may cause infections and non-hemolytic transfusion reactions to the recipients. What are the indications of leukocyte depleted red cells? They are indicated in patients who have 2 or more previous febrile reactions to red cell transfusion. Next, platelet concentrates. Now, this is a very commonly used concentrate. Two types of platelet concentrates are available. One is random donor platelets. Second is apheresis platelets. Random donor platelets or RDPs, they are prepared from whole blood donations. Single donor unit in a volume of 50 to 60 ml of plasma should contain at least 55 into 10 raised to power 9 platelets. Pooled unit, platelets are prepared from 4 to 6 donor units pooled into one pack to contain an adult dose of platelets in 150 to 200 ml of plasma. Next is apheresis platelets. That is, they are obtained by apheresis. One apheresis platelet concentrate is equivalent to 6 random donor platelet concentrates, and hence the number of donor exposures is reduced. Apheresis platelets contain 3 into 10 raised to power 11 platelets in 150 to 300 ml of plasma. Infection risk of platelets is same as that of whole blood. Storage, it's up to 72 hours at 20 to 24 degrees Celsius. Do not store platelet concentrates at 2 to 6 degrees Celsius like whole blood. What are the indications of platelet concentrates? Megakaryocytic thrombocytopenia, drug or radiation-induced hypoplasia, or any functional platelet abnormality, viral diseases associated with thrombocytopenia, for example, dengue, very commonly used, disseminated intravascular coagulation or DIC, that is encountered in ICU patients. Next is surgery or invasive procedure when the platelet count is less than 50,000. Contraindications are ITP and TTP, that is idiopathic thrombocytopenic purpura and thrombotic thrombocytopenic purpura. What is the dosage of platelet concentrates? In case of RDPs or random donor platelets, in adults, 1 unit is used per 10 kg body weight. So minimum 6 units are used in adult patients. And 1 unit of RDP will raise 5,000 to 10,000 platelets per microliters of blood. In case of apheresis platelets, adult, 1 unit will raise 25,000 to 3,000 platelets, 30,000 platelets. Platelet concentrates are to be infused generally within 4 hours because of the risk of bacterial proliferation, and they must not be refrigerated before infusion, as this will reduce the functional activity of platelets. Next portion is fresh frozen plasma, or commonly called as FFPs. Pack containing the plasma separated from one whole blood donation within 6 hours of collection and then rapidly frozen to minus 25 degrees Celsius or colder. FFP of 175 to 250 ml contains 70 to 80 units per deciliter of factor 8, factor 9, von Willebrand factor, and other clotting factors. So it is a clotting factor rich concentrate. Fibrinogen around 200 to 400 mg. Infection risk, if untreated, it is same as that of whole blood. Very low risk if treated with methylene blue or UV light inactivation. Storage is at minus 25 degrees Celsius or colder, and it may last for up to 1 year. It should be thawed before use in water, which is between 30 degrees Celsius to 37 degrees Celsius. So not very hot water. Dosage is 10 to 15 ml per kg. Labile coagulation factors, they rapidly degrade. So FFP has to be used within 6 hours of thawing. What are the indications of FFP? Replacement, in cases we need replacement of multiple coagulation factor. For example, coagulation factor deficiencies, as in liver disease, in anticoagulant overdose, in cases of depletion of anticoagulation factors in patients receiving massive volume transfusions or DIC or thrombotic thrombocytopenic purpura. Next portion is cryoprecipitate. Cryoprecipitate is prepared from FFP by collecting the precipitate formed during controlled thawing at plus 4 degrees Celsius and then resuspending it in 10 to 20 ml of plasma. 10 to 20 ml of cryo contains factor 8, fibrinogen, warm Willebrand factor, which is 40 to 70% of original FFP, fibronectin factor 8, which is 20 to 30% of original. Infection risk as for plasma, but a normal adult dose involves at least 6 donor exposures. Storage, it is stored at minus 25 degrees Celsius or colder for up to 1 year, and it must be infused within 6 hours of thawing. Each unit of cryoprecipitate raises factor 8 by 2%. What are the indications of cryoprecipitate? Mostly, they are used as an alternative of factor 8 concentrate in the treatment of inherited deficiencies of von Willebrand disease, of factor 8 deficiency that is called as hemophilia A, or factor 13 deficiency. As a source of fibrinogen, it can also be used in acquired coagulopathies. For example, DIC. Next are plasma derivatives. Albumin is available in various formulations, albumin 5%, albumin 20%, and albumin 25%. What are the indications of albumin? Albumin is transfused in cases of nephrotic syndrome, in liver diseases with fluid overload, in cases of hypoproteinemia because of burns, peritonitis, and in acute cases for volume expansion. Next component is immunoglobulins, concentrated solution of IgG antibody component of plasma. What are the indications of transfusing immunoglobulins? Idiopathic autoimmune thrombocytopenic purpura, treatment of immune deficiency states, hypogammaglobulinemia, and prevention of specific infections, for example, CMV virus. Next is factor 8 concentrate. Vials of freeze-dried protein labeled with content, usually about 250 international unit of factor 8, are available. Storage is plus 2 degrees Celsius to 6 degrees Celsius up to stated expiry date. Indications are treatment of hemophilia A, that is factor 8 deficiency, and treatment of von Willebrand disease. Next component is factor 9. Vials of freeze-dried protein labeled with content, usually about 350 to 600 international unit of factor 9. Storage is at 2 to 6 degrees Celsius up to stated expiry date. Indications, obviously in the treatment of deficiency of factor 9, that is hemophilia B, also known as Christmas disease, and immediate correction of prolonged prothrombin time. Next, we will discuss about transfusion reactions. Transfusion reactions are adverse events which are associated with the transfusion of whole blood or one of its components. They may range in severity from minor reactions to life-threatening events. They can occur during a transfusion, so they are termed as acute transfusion reactions, or they can occur days to weeks later after BT. So they are termed as delayed transfusion reactions then. Transfusing reactions may be difficult to diagnose first, as they can present with many non-specific symptoms and often overlapping symptoms. The most common signs and symptoms are fever, chills, urticaria, itching. Some symptoms may resolve with little or no treatment. However, respiratory distress, high fever, hypotension, and hemoglobinuria may indicate a more serious reaction. First, we will discuss about acute transfusion reactions. They may range from very mild symptoms to serious disease, serious events like mild symptoms like mild allergic events that is attributed to hypersensitivity to a foreign protein in the donor product. Anaphylactic reactions. Similar to a mild allergic reaction, however, they result in a more severe reaction. Sometimes this can occur in a patient with IgA deficiency who makes autoantibodies against IgA and then receive blood products containing IgA. Next type of reactions can be febrile non-hemolytic reactions. Generally, they are thought to be caused by cytokines released from blood donor leukocytes, these white blood cells. Septic reactions that are caused by bacteria or bacterial byproducts such as endotoxin, which may contaminate blood. Next, acute reactions can be hemolytic transfusion reactions. They can result in intravascular or extravascular hemolysis, depending upon the specific etiology. Immune-mediated reactions are often the result of recipient antibodies, which are present to the donor antigens. Non-immune reactions are also possible and can occur when red blood cells are damaged before transfusion. For example, by excessive heat or by incorrect osmotic conditions. Other reactions can be transfusion-associated circulatory overload, occur when the volume of transfused component causes hypervolemia or commonly called as volume overload. Transfusion-related acute lung injury or TRALI. Acute lung injury is due to antibodies which are present in the donor product. For example, human leukocyte antigen or human neutrophil antigen. They react with antigens in the recipient. The recipient's immune system thus responds and causes release of mediators, which can lead to lung injury and pulmonary edema. Clinical conditions that predispose the patient for development of TRALI and severe lung injury, they are infection or some recent surgery or already present inflammation. How to differentiate between signs and symptoms of TRALI and TACO? TRALI, that is transfusion-related acute lung injury, mostly presents with dyspnea, tachypnea, tachycardia, hypotension, and fever. And in case of TACO, transfusion-associated circulatory overload, some symptoms are common, that is dyspnea, tachypnea, tachycardia. But what are the differentiating symptoms are? Acute hypertension, jugular venous distension, rales in the chest, and BNP levels. Delayed transfusion reactions. Delayed hemolytic transfusion reaction, typically they are caused by an amnestic response to a foreign antigen that the patient was previously exposed to, generally by prior transfusion in the past, or because of pregnancy. Next delayed reaction is transfusion-associated graft versus host disease, GVHD. It results from engraftment of donor lymphocytes, which are commonly found in cellular blood products, into an immunocompromised recipient's bone marrow. The donor lymphocytes, they recognize the patient as foreign and react against the recipient's body. The patient's immune system is thus unable to clear the foreign lymphocytes. Though this is a very rare reaction, but if it occurs, it is a fatal event. Let us discuss about treatment of transfusion reactions. Suppose when a transfusion reaction is suspected, transfusion should be immediately stopped and the intravenous line should be kept open using appropriate fluids, usually 0.9% saline. A clerical check should then be performed. How? By examining the product bag and by confirming the patient's identification. Patient's vital signs should be monitored and recorded at every 15-minute intervals. Then a post-transfusion sample, blood sample should be drawn and sent to the lab. In addition, with the bag and the tubing if possible. The blood bank generally completes additional testing and clerical checks to rule out any incompatible transfusion. Mostly the treatment of specific reactions is supportive. For example, antihistaminics like diphenhydramine, most commonly called as AVIL, can be given for a mild allergic reaction, or an antipyretic can be given for a non-hemolytic febrile reaction. Now, if there is a suspicion of hemolytic transfusion reaction, first we have to collect first voided urine. We have to check bilirubin 6 hours post transfusion for any evidence of hemolysis. We have to check haptoglobin levels, and we have to check CBC. This is a chart showing morphological, functional, and biochemical changes in stored blood cell units. What are the functional changes in stored red blood cells? There is increased RBC rigidity, increased RBC lysis, decreased ATP production, decreased 2,3-phosphoglycerate, decreased pH, increased adhesion to endothelial cells, decreased vesiculation, and decreased O2 affinity. And what does aggregates in red blood cell supernatant indicate? They indicate free hemoglobin, increased potassium, increased lactate, increased sodium, increased interleukin levels, increased oxidized proteins, and increased peroxidized lipids. Now we'll discuss about a new concept, that is artificial blood, also called as synthetic oxygen carrying substances or synthetic blood. Artificial blood is an innovative concept of transfusion medicine where specifically designed compounds they perform the task of transport and delivery of O2 in the body, that is the function of blood, to replace this function of allogenic human blood transfusion. So, rightly called as artificial blood. They avoid blood transfusion associated diseases, and also they do not contain any antigen. Plus, they have a long shelf life and can be stored at room temperature for much longer time. So, in all, it looks like a very attractive alternative to blood. What are the different types? Oxygen carriers can be divided into two main groups: perfluorocarbon emulsions or PFCs. Second is modified hemoglobin solutions. First, we'll discuss about PFCs. PFCs are biologically inert materials. They can dissolve about 50 times more oxygen than blood plasma, and they are relatively inexpensive to produce and can be made devoid of any biological material. So, this will eliminate the real possibility of spreading an infectious disease via a transfusion. But they are not soluble in blood, which means to get them to work, they must be combined with emulsifiers. Also, they have the ability to carry much less oxygen than hemoglobin based products. This means that significantly more quantity of PFCs must be used. One product of this type has been approved for use by the FDA, but it has not been commercially successful. Why? Because the amount of PFC needed to produce a benefit is too high, as discussed above. So, what are the disadvantages of PFCs? Effective O2 delivery by PFCs, they occur at supranormal alveolar oxygen tension, that is about 400 mm of mercury, which is not practical. Then second is long half-life. This may look like as an attractive advantage, but the problem is with respect to dosage, it limits additional dosing of PFCs for 1 to 2 weeks. Why? Current generation PFCs have a retention time of around 1 week in reticuloendothelial systems, so it limits additional dosing. Thus, PFCs are essentially single dose drugs. Next option in artificial blood is hemoglobin based products. They are different than whole blood in that they are not contained in a membrane. So the problem of blood typing is eliminated. However, raw hemoglobin cannot be used because it would break down into smaller toxic compounds within the body. Also, there are problems with stability of hemoglobin in a solution. So various strategies have been employed to stabilize this hemoglobin. What are these strategies? They are either chemically cross-linking molecules or using recombinant DNA technology. Raw material hemoglobin-based products can use either isolated hemoglobin or synthetically produced hemoglobin. Now, what are the disadvantages of these hemoglobin-based O2 carriers? First, plasma hemoglobin is not a true blood substitute. It can replace only the O2 transport capacity, and it lacks totally the coagulation and immunological aspects of blood. Then, free hemoglobin avidly binds nitric oxide, which can cause hypertension due to vasoconstriction. Third point is regarding metabolism of free hemoglobin. It is identical to natural hemoglobin released from RBC destruction. This can cause increased bilirubin levels, amylase levels also increase. Consequences of hemoglobin metabolism may be similar to multiple blood transfusions like hemosiderosis and chronic iron overload. Now, some words about autologous blood transfusion. What is autologous blood transfusion? Blood transfusion in which donor and recipient are the same. What are the various types? Preoperative autologous blood donation, intra-op blood salvage, post-op blood salvage, and acute normobulimic hemodilution. So what are the advantages of autologous blood transfusion? First, as expected, it eliminates the risk of transfusion reactions, disease transmission, alloimmunization to RBC, WBC, platelets, and transfusion-associated graft versus host disease. Then it is safe and acceptable blood cover in Jehovah's Witness patients who are totally against blood transfusions. Then it is a safe transfusion in patients with multiple alloantibodies and rare blood groups. Readily available blood in major hemorrhage. Plus, it has a reduced demand on homologous blood supply. Pre-op donation stimulates erythropoiesis prior to surgery. So these were all advantages of autologous blood transfusion. What are the disadvantages? Expensive equipment and trained staff is required. Complex logistics are required for collection, storage, and transfusion. Contamination is still possible. Then tendency to over-transfuse the patient. Patient may become grossly anemic and develop coagulation defects during collection only. So preoperatively only, patient may develop anemia. Suitable for certain operative procedures only. That is why it is not very commonly and very exclusively used. If surgery delayed, then blood can become outdated and it may lead to wastage of that blood. Thank you, everyone.